I should say good evening. Thank you for joining us so late for you. I understand that the time difference is pretty dramatic between San Diego and Prague. So thank you once again for coming here. As Hannah said, my background isn't in clinical psychology or neuropsychology or in psychiatry. My background really is in gerontology, the study of aging, as well as epidemiology, which is in public health. And so I'm certainly interested in cognitive aging and what we can do to have an early identification of mild cognitive impairment and dementia. But I come from it at a more statistical, methodological point of view than one from a clinician's background. So I certainly welcome input from any clinicians on this call who might have some comments on this. And we'll be going over 3 papers that I collaborated with the Czech brain aging study. And so the topic today is about cognitive phenotypes, and certainly whether we view it or should view it as a gold standard, or whether it's limited, and how we should incorporate other measures of cognitive functioning or other methods and statistics to better understand risk of MCI and dementia over time. As Hannah said, I'm in the University of California, San Diego School of Medicine, and if you ever find yourself in San Diego for a conference, I'd be happy to say hi, and we can show you around California. So here's the outline today. First, I would like to kind of discuss with you what are cognitive phenotypes. All of you, I suppose, are neuropsychologists, so you probably already understand what cognitive phenotypes are, certainly from a clinical perspective, but we'll go a little bit into the methods and statistics of how to develop cognitive phenotypes. Do phenotypes exist for subjective cognitive decline and amnestic mild cognitive impairment? This is something that hasn't been studied all that much. It certainly has been studied almost to death in mild cognitive impairment alone, but whether cognitive phenotypes exist in SCD or AMCI, as they'll be referred to henceforth here, is not well understood in the literature. Are phenotypes associated with differential risk of progression? So this is a question that I think is in everyone's mind. If we do find different cognitive phenotypes within a clinical diagnosis, and we separate out these individuals depending on how they're functioning in different domains of cognition, is that going to be important? Will that tell us that there are differential risks of progression later on in their life? That's truly what we want to know. Certainly if we're going to be gathering all these data and partitioning individuals into different levels. And so that's something we can explore here as well. And finally, what about performance on individual tests? So cognitive phenotypes, as you probably can kind of understand right now, is a conglomeration of performances on different tests. But what about the predictive ability of certain cognitive tests within different cognitive domains on incident cognitive impairment or incident Alzheimer's disease and related dementias? So we're going to highlight 3 studies here. The first study was in the Journal of the International Neuropsychological Society, and that's going to be describing these cognitive phenotypes of subjective cognitive decline and amnestic mild cognitive impairment. And I have many of my co-authors here today and in the Czech brain aging study. The second paper will specifically be looking at those with subjective cognitive decline. And that will be using individual tests as predictive value to understand risk of MCI or dementia over time. And the third paper, which is currently in press, is also from the Czech brain aging study. And this is only among individuals with amnestic mild cognitive impairment. And so for those with substantial memory issues, are there certain cognitive tests within memory or within other cognitive domains that have some sort of predictive value of progression toward Alzheimer's disease or related dementias? And if that is the case, how can we better understand perhaps certain phenotypes within amnestic mild cognitive impairment that will index performance on certain measures? All right, so what are cognitive phenotypes? I wanted to show a figure here, and you can see there's a big conglomerate of green dots, of blue dots, and orange dots. And imagine these are 2 different cognitive tests on the x-axis and on the y-axis. So a cognitive phenotype is really just partitioning individuals, wherever they are on a variety of different tests, into groups that look more alike than dissimilar. And so the goal is to really, if you can see my pointer here, to make sure that the distance between any individual within these different clusters is very small, but that the difference between these 2 large colors is much larger. And so as you can see, this specific example has 3 clusters or 3 phenotypes that we found here. And this is the basis between understanding individual performance on cognitive tests across different cognitive domains and performance as it relates holistically to someone's overall functioning. So phenotypes are derived by individual tests, and they often use a machine-based cluster analysis. I'll describe briefly different approaches later, but essentially what's happening is you take all of the cognitive data and you normalize it. So you z-score it or t-score it, whatever you would like to do. And then you tell the computer essentially to run an algorithm that uses the different distance metrics that they have to figure out where each participant is in a cluster. And every participant will be put into a unique cluster. And cognitive phenotypes differ from traditional diagnostic categories because although we have, for example, amnestic mild cognitive impairment or multi-domain non-amnestic mild cognitive impairment, the cognitive phenotypes may differ from those traditional diagnostic categories and may look a little bit different. So why do cognitive phenotypes matter? Well, the clinical diagnoses categorize individuals by functioning in different domains. So certainly there's amnestic MCI, non-amnestic MCI, single domain and multi-domain. But within the literature over many years, we've started to understand that there are different subtypes of mild cognitive impairment that are specific to cognitive functioning in certain domains. So as you can see on the image here on the left side, there's substantial heterogeneity in performance between and within different diagnostic categories. And so what I mean here is that if you look at this gray box, for example, and subtle cognitive impairment, some individuals are scoring all the way 2 standard deviations above the mean on memory, while others are scoring all the way nearly at 4 standard deviations below the mean on memory. And there's individuals all throughout. What this tells me is that 2 individuals may have the same kind of cluster or diagnosis that could be amnestic or dysnomic or dysexecutive, but these individuals might differ pretty dramatically in how they actually score and how they're functioning. And so our goal is to take the heterogeneity that we see in a clinical diagnosis like mild cognitive impairment or subjective cognitive decline, and to parse out these homogeneous samples that will score more similar to each other than different. So as you can see on the left hand, these box plots are actually taken from a paper by Mary Machalda at the Mayo Clinic Study of Aging. And this paper found individuals with incident mild cognitive impairment who came to the memory clinic and then sought to create clusters or phenotypes of the incident mild cognitive impairment group. And what she found was that one group had more subtle cognitive impairment, not necessarily aggressive or something that would be life-changing, but enough that met the criteria for incident mild cognitive impairment. And then the other 3 clusters that she found was one was amnestic, particularly memory impairment, one was dysnomic or primarily language impairment, and one was dysexecutive or certainly issues with attention, processing speed, and executive functioning. And so among these different clusters, you can start seeing patterns. You can certainly see that language is mostly affected among the dysnomic group, but really it's affected among everyone. Most of these groups are not average or above the mean, they are below the mean. So there are these subtle differences that might tell us a bit more about how someone is functioning and their risk of dementia across time. So from the same paper, we can look at the median z-score clusters. And so she created an amnestic, dysnomic, and dysexecutive cluster, as well as that subtle group. And what we see is that these z-scores are pretty heterogeneous, that if you're in the dysexecutive group, really you have that deficit in attention, but you're relatively preserved for language, visuospatial skills, and memory. The opposite could be said for the dysnomic group that has very severe language impairment, but is relatively preserved to some extent, at least, for memory, attention, and visuospatial skills. So cognitive phenotypes cluster patients who look similarly, or they look alike, and it pushes people away who don't look alike. And that's important. We want the most homogeneous sample that looks as similar as possible among a very heterogeneous group of patients who come into the memory clinic. And there are different algorithms that cluster patients into different groups using cognitive data. So I'll kind of describe these three in very brief detail. The k-means cluster analysis only uses math. It strictly just uses a Euclidean distance to understand how can we mathematically separate people into different clusters. That's all it's doing is math. And so if you have no preconception of how something overarching is affecting the clustering of your different individuals, then the k-means cluster analysis is a pretty good option. And this is certainly what Mary Machalder and many others have done in their papers. A second method is called latent class or latent profile analysis. And this differs from k-means cluster analysis because it actually is using a model. It's creating a latent structure that is suggesting to impact individuals into different clusters. So for example, if you believe that certain Alzheimer's disease neuropathology is putting individuals into different clusters, this type of clustering technique might be better because you have a theoretical or at least a biological backbone, a latent structure that might be influencing individuals' performance. And finally, there's the growth mixture model. This is similar to the latent class and profile analysis, but instead of looking at individuals cross-sectionally at one time point or at baseline, this is looking at heterogeneity in clusters as they function across time. So if you're interested in looking at cognitive change among the amnestic, the dysnomic, and the dysexecutive group, this is certainly what you would want to do. And instead of finding these clusters in this Z-plot right here, we would be looking at these clusters across time. All right, so data-driven MCI phenotypes exist. Certainly in the literature over the past 15 years, there have been many characterized phenotypes, including that primary amnestic mild cognitive impairment, a dysexecutive subtype, a dysnomic subtype, visuospatial impairment, and then certainly the mixed or the multi-domain MCI that is certainly on the progression from healthy control all the way through Alzheimer's disease and related dementias. But patients with MCI are heterogeneous. They are dissimilar. They don't look like each other, certainly in their level of impairment and the affected domains. Although you'll have maybe 100 patients in a given memory clinic study, there may only be 2 or 3 different clusters of individuals that look very much so alike. And so understanding how people look similar is just as important as understanding how individuals look different. So the heterogeneity in subjective cognitive decline is hypothesized really from this paper, from Mary's paper. What we see in this subtle cognitive impairment group, which, like I said, is a little bit different from subjective cognitive decline in that these are individuals diagnosed with mild cognitive impairment, but have very minimal impairment. We see heterogeneity across all of the different cognitive domains here. And what that tells us is that perhaps there could be some heterogeneity in subjective cognitive decline, which is only perhaps a little bit less impaired than the subtle cognitive impairment cluster that Mary Machalder and her colleagues had found. And so if you have individuals scoring as low as 3 standard deviations below the mean to all the way to 2 standard deviations above the mean, what that tells us is that this heterogeneity is important to start conceptualizing and measuring. We also know that SCD, subjective cognitive decline, differs pretty remarkably from mild cognitive impairment. And so although we can't be certain that there is going to be heterogeneity, we can certainly guess that based on the subtle cognitive impairment group that there will be heterogeneity, certainly enough to create clusters within a study. The same thing could be said for amnestic mild cognitive impairment. What we see in these green bars is very similar to above, that individuals are nearly 4 standard deviations below the mean, all the way to 1 standard deviation above the mean in different cognitive domains. But some individuals will look dissimilar to each other. So once again, the heterogeneity in this group will allow for easier separation of the patients into different clusters and phenotypes. And then the outcomes of these clusters and phenotypes can be tracked over time. That might be progression to dementia, could be progression to functional impairment, all these different outcomes of interest. So the first study was with the check brain aging study, and we looked at 163 patients with subjective cognitive decline and 282 patients diagnosed with amnestic mild cognitive impairment using traditional criteria, Peterson and so forth. So here's the story of 3 clusters. Performance on individual tests was first Z-scored, and there were many different cognitive tests that we include across all different domains. And what we did was we partitioned them into different clusters. And so what you see here is a 3-profile solution, or 3 different phenotypes. In the top graph, we see a high-functioning group that's in gray up here. All of these Z-scores are within the same diagnostic category. So this is in comparison to the typical or average individual with subjective cognitive decline. This is how they're scoring. One group is certainly high-functioning. The orange group, I would suggest, is pretty much the average cluster, with the y-axis being the Z-score here. They might have some issues with processing speed and attention, but overall, they're pretty much so an average group. And the blue line is really the poor functioning cluster. Compared to the average SCD patient, these individuals have relative impairment, certainly not clinical that would meet the cutoff of mild cognitive impairment, but enough that it showed up certainly here across all different domains: memory, language, executive functioning, attention or processing speed, and visuospatial skills. We also found a 3-cluster solution for amnestic mild cognitive impairment on this bottom graph. So we see a minimal impairment cluster on this blue line. These individuals certainly have memory impairment that would give them a diagnosis of amnestic mild cognitive impairment, but compared to the average individual with AMCI, they're doing quite well. We then characterized a group called dysnomic amnestic mild cognitive impairment, in which the impairment in memory is quite severe, and they also have some impairment in language, but their executive functioning, attention and processing speed, and visuospatial skills is relatively preserved or quite well. And then there's the multi-domain cluster. And this cluster has significant impairment across all different domains, with special impairment across executive functioning in comparison to the other groups, as well as certainly attention, processing speed, and visuospatial skills and executive functioning. So this is a group that one would be assuming that these individuals would progress to dementia. They certainly look very similar to individuals with the early stages of Alzheimer's disease, but they may have preserved functionability. And so this is certainly a cluster of AMCI that we should look out for in the future. So the next question you might have is, did the SCD clusters or phenotypes progress to mild cognitive impairment or dementia at different rates? And from this graph, we see the high functioning group, we see an average SCD group, and then the poor functioning group. And the y-axis is their survival probability, which just means really the time to progression for mild cognitive impairment or dementia. And so as you can see, across all 3 groups, there were only 25 individuals who progressed. So not that many, and this could be a sample size issue. But what we see is that there is differences, certainly between the poor functioning group compared to the average SCD and the high functioning group, but perhaps not among those high functioning and average groups. However, when we start controlling for age, sex, and education, all these differences go away, so to speak. The blue versus the orange group, it certainly has a higher adjusted hazard ratio, but the confidence interval includes 1, which means it's not statistically significant anymore. The blue versus the gray group is even higher, but once again, the confidence interval includes 1 due to this small sample size, and therefore it's not statistically significant. And the difference between orange and gray is quite minimal, only 11% increased risk. And once again, that confidence interval includes 1. So none of these groups are statistically different from each other, though this could be an issue with sample size. There were only 163 patients and only 25 individuals who progressed to MCI or dementia. And so perhaps we would just need a longer period of time and certainly a larger sample size to perhaps understand if these phenotypes are progressing at different rates. All right, what about the AMCI clusters though? Do different AMCI phenotypes progress to dementia at different rates? We see the blue line here for the minimal impairment group, the orange line being the dysnomic AMCI group, and the gray line being the multi-domain AMCI group. And the cumulative number of events is much larger. As you can see here, 15 in the first group, 40 in the second group, and 21 in the third group. Mind you, the dysnomic group had the largest sample size, and so that's why there were the most people, but their probability is still higher than the multi-domain AMCI. What we find here is when you're not controlling for age and sex and education, there are statistical differences between these three groups, which is pretty exciting. We further find that when you do control for age and sex and education, we see a dose-response relationship here between the baseline cognitive impairment, their level of impairment, if they're in the minimal or the dysnomic or the multi-domain phenotype, on the subsequent risk of progression to dementia. So what we see is that when we compare the gray, the multi-domain group, to the minimal impairment group, the blue group, their adjusted hazard ratio is 5.71, which is pretty high. The dysnomic compared to the minimal impairment group, that adjusted hazard ratio is 2.71. So that could be interpreted as a probability as well. They have a 171% greater risk of progressing to dementia across these years. And the gray to the orange group also has an increased risk by 110%. And so what that tells us is really there's a dose-response relationship. Depending on your baseline cognitive functioning, when you come into the memory clinic and you're diagnosed with amnestic mild cognitive impairment, that baseline level of functioning is associated with your risk of dementia across time. And you can be partitioned into different groups. So we found 3 in the Czech brain aging study: minimal, dysnomic, and multi-domain AMCI. But certainly, if you're looking in a different diagnosis category, there could be a different number of phenotypes or clusters there. All right, so what does this really tell us about the state of science on cognitive phenotypes? Well, we know that cognitive phenotypes exist, and certainly they will exist among heterogeneous diagnostic categories like subjective cognitive decline and mild cognitive impairment, in which you have 2 individuals with the same diagnosis, but drastically different cognitive functioning. And not all phenotypes or clusters will progress to MCI or dementia at different rates. Now, this could be due to what I suppose would be sample sizes. And so the individuals with subjective cognitive decline, there were just so few of them. And once again, so few of them, only 25 progressed to MCI or dementia. And so these types of analyses need to continue in large samples with a very long time of follow-up. That will help us understand really conclusively, or perhaps even in causal nature, whether the phenotypes track onto different rates of progression toward dementia or mild cognitive impairment. All right, but what about cognitive test performance? So I showed you their performance on different cognitive tests across different cognitive domains. And many of you, of course, are neuropsychologists. You might be wondering, well, Dylan, the cognitive phenotypes are cool. They might partition individuals into different clusters, but I would maybe care about the predictive value of certain cognitive tests. Might that be also helpful in helping us understand how someone might progress across the cognitive continuum? So we know that baseline cognitive performance tracks remarkably well to future risk of Alzheimer's disease and related dementias. And we also know that certain cognitive tests may be more predictive of future progression, but really this could differ between SCD and AMCI. The same cognitive test, for example, the RAVALT, the same cognitive test might be predictive among AMCI, but maybe not as predictive among SCD, or vice versa. So it's one of those situations in which the only way to understand this is to do the same analysis across 2 different samples to better understand what cognitive tests, certainly at baseline when they come into the memory clinic, is associated with future progression. So this is the second study. Once again, this is in the Czech brain aging study and in their memory clinic. We looked at 131 patients with subjective cognitive decline and then tracked them as long as we possibly could in the Czech brain aging study. And so when we tracked them, I believe the furthest point was almost 15 years of follow-up. What we found was that we had 76 individuals that we coined as stable SCD. These are individuals who did not progress to mild cognitive impairment or dementia. And then we had 55 progressors. These are individuals who did progress upon follow-up. 53% went to non-amnestic mild cognitive impairment, 44% went to amnestic mild cognitive impairment, and 4% progressed directly to dementia without going to a mild cognitive impairment. So when we compare AMCI and NAMCI in this group, what I wanted to do was to understand cumulative incidence functions. So a cumulative incidence function tells us the relative risk or estimated marginal probability of an individual progressing to two different diagnoses that are mutually exclusive and are competing risks. So what that means is that if I'm diagnosed with amnestic mild cognitive impairment, that would preclude me from being diagnosed with non-amnestic mild cognitive impairment and vice versa. So what we see is that progression to non-amnestic mild cognitive impairment in the SCD group is quicker. It happens at an earlier stage than progression to AMCI. And so if you look across this graph, if we're looking at the probability of 20%, for example, that's reached by 4 years for non-amnestic mild cognitive impairment versus 5.5 years for amnestic mild cognitive impairment. So what this tells us is that if individuals are going to progress, they might progress to non-amnestic or amnestic mild cognitive impairment. But if they are progressing to AMCI, it could be later on. And so that's why continued follow-up to understand how their memory is certainly crucial in a clinical setting. And to understand how NAMCI is affecting them is absolutely crucial as well. So what tests are predictive of progression? Well, across the whole sample, individuals with NAMCI and AMCI and dementia, what we find is that really there are a handful of tests. They're raveled in different subsections of it, like the first trial, trials 1 through 5, and the fifth trial, the peak performance, but also the trails making test part B, the Ray complex figure test, recall proportion or portion of it, and the trails A. However, when you study all of these tests, I believe this might be 18 or so different tests, you increase the risk of type 1 error, finding something that really shouldn't exist, but you might have found it just because. And that's an unfortunate problem in statistics. And so what we do is we correct for type 1 error inflation, as many of you know. And so once you correct for all these different tests, we found that really it was the RAVEL 1 and the RAVEL 1 through 5 that some of the trials that are most predictive of progression. And some of you might ask, well, this is interesting for everyone in SCD. I can administer the RAVEL and take different subcomponents and try to understand if that's predictive of their future progression. But what if I'm curious about amnestic mild cognitive impairment or non-amnestic mild cognitive impairment specifically? And so we did a follow-up analysis where we looked at certain tests as their sensitivity for MCI type, amnestic versus non-amnestic MCI. And what we found was for AMCI converters, it was really the RAVEL 5 and the Ray complex figure test that were most predictive of progression, including the other components of the RAVEL, like the RAVEL after 30 minutes of delayed recall, as well as the RAVEL sum of trials 1 through 5. And the Boston naming test was inversely associated. So they should have excellent functioning on the Boston naming test if they're not going, or excuse me, if they're going to progress to AMCI. But for the NAMCI group, the non-amnestic mild cognitive impairment, it was really the RAVEL 1, the trails making part B, and the Boston naming test. And so what that tells us is it's really perhaps executive functioning and language that's associated with their follow-up progression, which makes sense. Non-amnestic MCI might be individuals who have greater impairment in language and executive functioning. But what surprised us, or perhaps surprised me because I'm not a clinician, is that even a component of the RAVEL was associated with NAMCI, and that's the first trial. So we hypothesized that maybe it's that the first trial is so overwhelming that the individual, the patient, the memory clinic patient is trying to understand the different components of the test and understanding this in more of a working memory processing speed way, not as much as a direct immediate or delayed recall memory way. And so perhaps the RAVEL 1 is more interesting to some individuals than the RAVEL 5 or 1 through 5 or delayed recall.
Dylan, I'm sorry to interrupt you, but we do have here a question.
Sure.
Maybe ask Andrei.
Can you listen? Can you hear me?
Yeah.
Yes.
Hi, Dylan. I would be just interested in the paper. The paper was published by iOS Press and it's not accessible. Would you be so kind at the end of the presentation to send it as a PDF, if it's possible? If it's not, no problem.
Yep, absolutely. I'll send all 3 papers to Hannah and she can distribute them.
You're very kind. Thank you very much.
Of course. Thank you. Thank you. So what have we learned here from this second study? Well, baseline performance on the RAVALT was associated with future progression from SCD to MCI and dementia, but verbal memory performance specifically was more strongly associated with AMCI, whereas executive functioning or language performance was more associated with non-amnestic mild cognitive impairment. So this means a lot, clinically speaking. If we test individuals in certain cognitive domains and track their performance on certain tests, we might be able to predict progression to mild cognitive impairment much quicker than if we were to just give them a whole battery and assume that their performance across the whole battery is indicative of future progression. So then there's a third study, and this study looked at amnestic mild cognitive impairment alone, 270 patients who came into the memory clinic at Motel, and perhaps also the Brno site. I think it was just Motel though. And what we found is that there were 126 stable AMCI and 144 progressors who went toward dementia. And of the 144 dementia progressors, 72% had Alzheimer's disease upon follow-up. 17% had a mixed dementia, which was vascular and AD specifically. 5% had Lewy body dementia, 4% the behavioral variant version of frontotemporal dementia, and 1% had vascular dementia. From this graph, on the y-axis, this is a Kaplan-Meier survival curve. This is the probability of not converting to dementia, so the survival. And what we see across here, the cumulative number of incident dementia cases. And what you can see from this graph, this is really the nonlinear methodology to better understand how quick someone is progressing to dementia. What we see just from this graph is that by 5 years, around here, the vast majority of patients who are going to progress will have already progressed. And so what this tells us is that the progression for AMCI, at least in the memory clinic, in the checkpoint aging study, is typically among individuals who will come back regularly. And when they are coming back regularly, they convert to dementia, they progress to dementia quickly. All these different little lines that you see here, a little line right here, here, these lines represent censored patients. So a censored individual, from an epidemiological perspective or public health methodological perspective, is an individual who dropped out of the study, was lost to follow-up, or had died. And so what this tells us is that there are individuals who come to the memory clinic in the beginning at 0 years. They say, thank you very much for this cognitive assessment. You've taught me a lot about my functioning. And then they proceed to fall off the face of the earth and never come back. And so this is an issue across all prospective cohort studies, that some individuals will leave. There will be some level of attrition. And so the Kaplan-Meier curve uses this level of attrition to better understand how the progression looks at a probabilistic model when you control for that selective attrition. All right, so there were 144 cases. You can see certainly by 10 years, 11 years, everyone who was going to progress had already progressed. So which tests are predictive of progression? I know this is a really large and full of numbers table, so I'll try to condense this as quickly as possible. We have the Cox proportional hazards regression models, where the baseline neuropsychological performance is being used to predict conversion from amnestic mild cognitive impairment to any type of dementia, Alzheimer's or otherwise. And I'll put a note here that we did a sensitivity analysis, and that the tests that are predictive of any kind of dementia are also predictive of Alzheimer's disease specifically. So it's not that we're being biased by the other forms of dementia that we saw there. What we note is that there are adjusted hazard ratios for age and sex and education, as well as the associated p-values. We have the area under the curve, which is the predictive ability of these different tests. Anything above 0.800 was given this little hat here. That is an excellent predictive ability and a test that we should certainly consider in the future. Then we wanted to control for the mini mental state exam or the global cognition. So this is the adjusted hazard ratio after we control for the MMSE. And then we wanted to control for depression, as well as the apolipoprotein epsilon 4, any type of allele, 1 or 2, to try to understand if these tests are predictive of progression after controlling for some of the genetic risk of Alzheimer's disease and related dementias. So what we see is that the AVLT, or the RAVOLT 1 through 5, the sum of the trials, the 30-minute delayed recall version of it, the Ray complex figure recall, the logical memory immediate recall, and the logical memory delayed recall, and the semantic verbal fluency animals are the most predictive. They have the best AUC, or the area under the curve, above 8.800. But what you can see is that most tests, when you look at the 95% confidence interval, most tests have a similar confidence interval. And what that tells us is that although there are subtle nuances, some tests are perhaps a little bit more predictive than others, the vast majority are quite good. There are some tests down over here, the digit span, that are notoriously bad at predicting future progression. And even if you're doing forward or backward digit span with numbers or score, they don't predict certainly as well as something like semantic verbal fluency. And what you can also see here is that when we control for the global cognitive functioning of the individual, because we did see, if you remember from the first study, the difference in a dose-response relationship, that if you had more impairment at baseline, you had a greater risk of progression. So this is why we wanted to control for global cognition here. What we find is that the tests that were predictive originally, these ones, as well as the ones that have a pretty high AUC, are still fairly predictive, but you can understand their adjusted hazard ratio has dramatically reduced. And so instead of a 2.43 adjusted hazard ratio, or 143% increased risk of progression to dementia for scoring 1 standard deviation below the mean on logical delayed recall, what we see is that it had only dropped to 105% increased risk. And some tests became statistically irrelevant at this point when you control. So for example, the phonemic verbal fluency went from being statistically significant to not significant at all. When you further control for the depression that we might see among this group, as well as the apolipoprotein epsilon 4 alleles, what we see is that most of the tests that were predictive originally are still predictive. And in fact, some are even more predictive, that depression and the genetic risk actually controlled for part of the variance that wasn't necessarily controlled for originally. And so that's fairly exciting here too. So are tests predictive of progression after we control for memory performance? We are looking at individuals with amnestic mild cognitive impairment. So some of you might ask, if we control for memory, what tests are still excellent after we control for their baseline memory performance as well? And what we see is that actually, yes, poor performance on the digit symbol test and the semantic verbal fluency vegetables specifically test associate with the risk of progression after controlling for age, sex, and education, global functioning with the MMSE, as well as delayed recall memory performance. So what have we learned here? Well, there are tests within the same cognitive domain, for example, semantic verbal fluency and phonemic verbal fluency, that have vastly different predictive ability. That's important for us to understand from a clinical perspective, because if a test has very poor predictive ability, what's the purpose of burdening your patient with the additional time needed to complete that task? We also see that non-memory tests associate with incident dementia among patients with AMCI. And this was once again supported by that first study on cognitive phenotypes, that a dysnomic or multi-domain AMCI group might exist. And so we're showing that individual tests within those different clusters of language and executive functioning and visual spatial skills may also progress individuals toward dementia. And then we also see that semantic verbal fluency and performance on the digit symbol test, which is more processing speed, working memory, and so forth, were associated with progression to incident dementia, even after controlling for their global functioning and their delayed memory performance, which was highly predictive of progression to Alzheimer's disease and related dementias. So cognitive phenotypes versus individual tests. I'm sorry to be the bearer of bad news. My own opinion, and maybe your opinion differs from mine, which I would encourage, is that there's no clear gold standard here. From these different papers, I think what we found is that cognitive phenotypes provide a holistic view of the patient's cognitive functioning, but they might not be as clinically meaningful when we're looking at certain outcomes. For the individuals with subjective cognitive decline, progression to dementia didn't differ all that dramatically. And although that could be a sample size issue, it may not be. It may be that the phenotypes don't matter as much in that group. What we also found is that performance on individual cognitive tests may be highly predictive of future impairment, but many of you know that even healthy controls will perform abnormally on occasion when they come to a memory clinic. And so that begs questioning if we should be incorporating a different standard. I've recently tried to understand this concept of base rate, and many of you certainly understand base rate, and we could perhaps incorporate that when we develop cognitive phenotypes. And that might help us better understand if cognitive phenotypes could become a gold standard one day when we start incorporating these other factors. So is there a solution to this problem? Well, cognitive phenotypes are necessary to inform our understanding and future development of diagnostic categories. From my understanding, there is no clinical diagnosis of dysnomic type AMCI. Certainly someone might be diagnosed with multi-domain AMCI, or excuse me, multi-domain non-amnestic mild cognitive impairment, which would be dysnomic and, multi-domain amnestic mild cognitive impairment, which would be dysnomic and memory impairment. But to have a specific word that characterizes a whole group, I think is very meaningful. Meaningful for the patient to start to understand where they are in the cognitive continuum, but also meaningful for the clinician to understand their future risk of progression. We do know that the cognitive phenotypes are limited by the predictive accuracy of the individual tests used to create them, right? So if we use tests that have no predictive accuracy to create the phenotypes in and of themselves won't be predictive. Therefore, I would suggest that the phenotypes should be carefully derived from the highly sensitive and specific tests, like what we've shown in these follow-up studies. So if I could have done this over again, if I could hop into the time machine, go back in time several years, perhaps I would do the last two studies first to identify the tests that are most sensitive and specific, and then I would create the cognitive phenotypes later on. But this is part of science. We make mistakes and we try to do better in the future. So these are the three reference papers. I'll send to Hannah and others, and she can distribute them among all of you. And these are some additional references I would suggest looking through. On the YouTube version of this video, you can certainly pause the screen and look. Many of these papers are certainly about cognitive phenotypes and what has been done previously in the literature. And then a couple of these are more focused on, for example, biological phenotypes. That's something I didn't mention as much, in that we're just looking at cognitive performance and even just baseline cognitive performance. Perhaps we need to expand our breadth of study to understand longitudinal cognitive decline and phenotypes in this longitudinal way, as well as biological heterogeneity. I know some of us here are more neuroscientists and have a very large understanding of the neuropathology of Alzheimer's disease and how different individuals will cluster by their biological heterogeneity. And then I did try to include two different articles here by Decker and Tomasz Nikolai here that really look at reducing misclassification bias with base rate. And base rate is something that I know very little about because I'm not a neuropsychologist, but I'm hoping to learn more about in the future. And base rate can hopefully help us understand or derive better cognitive phenotypes that would help us really make a predictive cluster of individuals. So I have to acknowledge all of my CBAS collaborators. They're all really wonderful individuals in addition to being brilliant scientists and clinicians. So thank you very much for your continued support. And I look forward to collaborating you through the future. And now I would like to hear your thoughts. So feel free, please contact me day or night. It might be night considering time difference. Here is my email down here, and you can read more about my other non-cognitive aging work here on my website. Hannah, I think you might be on.
Yes, I'm muted by now. Thank you very much, Dylan, for your wonderful talk. It was really very, very nice to go through all the studies in so detail. And now there is time for your questions. So if someone from the audience has any question now, they are really welcome. I would like to really appreciate your the last slide or the last two slides where you gathered all the information, because through all the time I was thinking about the practical application of the cognitive phenotypes, because I really found them very exciting. Maybe this is because this is something new for us, but to me as a clinician, I would say the last two studies are more applicable into our daily routine clinical practice, because this gives us information about what tests really to choose when we are trying to make the cognitive neuropsychological batteries. So that's it. But I was excited about your gathering, and I would like to ask you, or you wanted to mention something?
No, go ahead, sure.
What do you think about, my question is about, what do you think about another study which would look at associations between cognitive phenotypes and biomarkers? Is there anything like that by now, or are you thinking about it?
That's a great question, Hannah. It's almost like we have the same brain. So there is one paper down here that did look at biological heterogeneity, and they did add cognitive measures to their biological heterogeneity. So they kind of did it the opposite way of what you just described. They first did phenotypes by biology, I believe, and then they tracked cognitive functioning. But certainly what could happen is we do the cognitive phenotypes first, and then we look at their biological functioning, and certainly their Alzheimer's disease neuropathology and genetic risk and others. So absolutely, I would love to incorporate that. You know, one other suggestion might be that they could be incorporated into the phenotypes, that instead of only creating the phenotypes from cognitive functioning, that it could be inclusive of APOE or inclusive of volumetric data, right? This is the kind of information that correlates very well with cognition, but certainly is interesting to different audiences. And so that might be a really wonderful follow-up. And like I said, understanding this longitudinally and understanding different outcomes across time will be important.
Mm-hmm. Thank you. I think this is this could be very worth, especially in the SCD population, which is really heterogeneous by now. So I think it could bring really interesting information for the future and also for their clinical follow-up.
Absolutely, absolutely, I agree. I have seen some increased interest in understanding more the biological phenotypes of SCD, and I think this is mostly influenced by those Jack curves, Clifford-Jack's curves. So we need to understand that.
Mm-hmm. So I think we do have here another question. Andre, you raised your hands.
Thank you for the presentation. It was really nice. And these ROCs and AUCs, it's very valuable because if you like to compose a battery, just really sensitive to some of the MCI subtypes, it's a very good information. My question is, because you mentioned that you're from San Diego, and San Diego is automatically Mark Bondi, and I would be very much interested. You're clinical or cognitive phenotype you mentioned are, these classical Petersons, or at least, you mentioned MCIs, which were statistically defined. But Bondi is working on this concept of subtle cognitive decline, like SCD. So I would be very curious, what's your opinion on, like SCD in comparison to MCI? And if you would like to use the construct in future, or if you think it's clinically valuable, and so on and so on. That's my question.
Sure, thank you. Thank you very much. Yeah, we're actually very lucky to have so many really wonderful and brilliant neuropsychologists and neurologists here at the University of California, San Diego. And SCD is very interesting to me from a non-clinical perspective. It tells us a lot about an individual because they might be coming to a memory clinic with memory complaints or certain cognitive issues that they deem to be clinically important to them in their home and in their livelihood, but may not be scoring deficiently or worse on their cognitive tests. And certainly this might be related to cognitive reserve and other factors that we need to better tease apart. But I do find value in the SCD diagnostic group, particularly once I looked at their progression to AMCI and non-amnestic mild cognitive impairment. If we don't examine individuals who have these complaints or have that subtle cognitive decline, then we're missing part of the conversation on early detection. Right. Early detection needs to include healthy individuals with memory and cognitive complaints, as well as individuals who are already on that cognitive continuum toward Alzheimer's disease and related dementias. And so I find it interesting. Clinically, I'm sure it's very important as well. What I find difficult, though, is that in our first study, two of the phenotypes looked so similar to each other. They were incredibly high functioning. Many of them had very high educational attainment. And so they might have been retired physicians or psychologists or medical faculty who were at Charles University or Motel. And so what that tells me is that perhaps these individuals, if they didn't have the educational attainment and the cognitive reserve that they've built across their entire lifespan, maybe they wouldn't be testing in SCD. Maybe they would be testing in more of that subtle cognitive impairment diagnosis that Mary Machulda first kind of coined in her Mayo Clinic Study of Aging paper. And that's important. That's really interesting because as the world becomes more and more educated and our cognitive reserve is enriched by all these different wonderful things that the world allows us to kind of partake in, perhaps the way that we view cognitive reserve and the way that we view cognitive impairment needs to change. One thing that I'm continuing to examine here at UC San Diego is nonlinear modeling of cognitive decline. We know some of us suggest certainly that cognitive decline is nonlinear and that it could be quadratic, but some of us who like statistics too much, like me, might suggest that it could be even more silly than that it could be a little curvier, maybe a cubic relationship exists. And so I've been doing some nonlinear modeling that hopefully in the future all of you could read, and that's just using longitudinal data in the health and retirement study. But this nonlinear modeling may help us better understand SCD, may help us better understand that subtle cognitive impairment in MCI, and certainly will help us understand progression across the cognitive continuum. I hope that answered your question all right.
Okay, thank you, Dylan.
Sure.
So I think we have reached 6 o'clock. So there is, I think, time for one quick question by now. So if there is anyone, do not hesitate.
And if you have other questions, feel free to send an email, or I'm more than happy to collaborate and provide methodological or statistical consulting on these types of questions. It's my bread and butter and something that I really do love, in addition to, I see the value of it, of course.
So, okay, so thank you very much, Dylan, once more. It was very nice to have you here, really. It was very nice to cooperate with you. I'm looking forward to our future collaboration and also to your future studies coming from San Diego. So thank you very much. I think I will stop recording by now.
Sure, thank you very much.